Welcome to the Sustainable Clinical Medicine podcast. I am your host, Sarah Smith. I am a practicing rural family physician and the charting coach. This is the podcast for physicians and advanced practice providers who are ready to step back from the busyness of their clinical day to share ideas, question everything, and redesign their clinical day. We are redesigning clinical medicine to create sustainable clinical days and create time for our lives outside of medicine. Join us for discussions with world experts who are helping design sustainable models of clinical medicine and the physicians or clinicians who have discovered or designed sustainable models of clinical medicine for themselves. Hello, and welcome back, everybody. Today I have with us Dr. Kerri Lockhart, who I have met through the trauma-informed coaching space. So I'm going to let her introduce herself to you. Welcome, Kerri.
Hello, everyone who's watching, and Sarah, it's good to be back with you. I'm Dr. Kerri Lockhart by training, but I'm pretty informal. Lodestar, we just kind of go by first names. So where do I start? I am a general pediatrician by training. I love the babies, but we see them from 0 to about 21. So technically I see some adults too. I came to be a pediatrician. Right now, I should just tell you a little bit more about my life now. I live in Chicago, Illinois, just outside of Chicago, Illinois, but I'm born and raised in Chicago. If you know anything about Chicago, I'm on the west side, which is a community that's been poorly resourced for years. And so working class community I grew up in, and like a family, kind of community. So first in like 2 buildings where my great-grandmother and some aunts and uncles were here, and my grandmother and my mom and other aunts and uncles were there. And so we were always together as a family. And then moved. My sister says we moved when we were 5. I think we moved when we were 7. I'm not sure, but we moved at some point. And everyone stayed in the city of Chicago, but just kind of dispersed a little bit, and we always still stayed really close. So really close to my family, even more so now. I went off to high school and went to a boarding school for high school, obviously college and medical school and all that stuff. And I think I was like missing the connection of being close to family after being away for high school. And I moved in with my twin sister and brother-in-law, what was supposed to be temporarily, and that was 10 years ago. So I live with my twin sister, brother-in-law, my niece and nephew, and I love it. I get to see them grow up. My nephew wasn't even born when I first moved in with them. So we live just in a suburb right outside of Chicago. Started out about 8. I told my mom I wanted to be a baby doctor. That started, I'm an asthmatic, and as a kid, I was a pretty poorly controlled asthmatic. My mom has asthma. She's doing really well now, but she was an asthmatic who was what is called steroid dependent. And everyone's doctor, so you probably know what that, you know what that means. She was pretty severe. And I have an older sister, 11 months older, who is who is an asthmatic as well. So my twin sister and my father, oddly enough, didn't have asthma. And so I have 2 half siblings, a half brother and a half sister. They don't have asthma at all either. So it was multiple like hospitalizations and being, kind of well cared for. Once I got in the hospital, they took good care of me. The process of getting there sometimes didn't feel like we had the information to prevent that. Collectively, that led me to say, I want to be a baby doctor. No idea what that meant. And so I kind of did this twisty journey to get there. I thought I would retire. I thought I'd be, 60, 70, I don't know, 80, taking care of little babies. And it didn't take me very long to realize that it wasn't a sustainable way to make a living, at least for me. I'm very open about being neurodivergent, and my experience as a neurodivergent physician was that medicine is not really designed to support our needs in a way that's sustainable. And so I practiced for just shy of 10 years, and it was severe burnout of, just not really having what I needed around lots of things. But I know what's really kindred to your, audience, charting. I really struggled to keep up with charting. I would run behind, and I identified some things that really helped me navigate that. And there was some, I don't know what the word was, but there was really a lot of, I think, resistance to doing things in a new way because we've always done it this way, and everyone else is doing it. Sort of like, why can't you? And when you become a physician, I often say there's a little bit of an indoctrination well before you become a physician. You kind of watch doctors and you are mentored by doctors, and you learn what it means to be a good doctor. And so, I ask myself sort of the same questions. Why can't you? Your colleagues are doing it with the same support. So I just tried to do it for quite a while. And then eventually I just realized, like, this isn't fair. For you wouldn't do this to your patients. You wouldn't say your classmates are doing this. I have ADHD, and you wouldn't say they're doing classwork with the same resources. And so I'm a huge Brene Brown and I remember one of the very first things I heard her say was, if you take a lot of joy in helping people and struggle to ask for help, then there's likely some shame in there. And so I really had to contend with the shame that I had about my ADHD, because I really was an advocate for my patients, even to, challenging parents, in a gentle way sometimes about the beliefs that prevented them from supporting their children. But I wasn't doing that for myself. And so finally I just said, no more. And that struggle to advocate for myself throughout being a clinician, along with my struggles with ADHD, eventually just wore me down. And I describe it as falling off a cliff. I think everyone around me saw that I was kind of heading, in the direction of burnout, and I was a little bit in denial. And I like to describe myself as self-aware, but, again, I didn't want to admit that, like, I can't doctor. And I came home one day and sat in not this actual chair, because I have a new desk chair, but in my desk chair and cried for 2 hours. And about an hour and a half into that, I called my mom, and she said, you can't take care of patients like this. And I had been on leave a few times throughout that year, because what I didn't share is my intern year, I had breast cancer, which is when my ADHD kind of really, the bottom fell out. And I was in the process of, after years of kind of off and on having some odd imaging, I had a double mastectomy prophylactically. And so I'd been off, on some leave of absences that year, which one would think, well, you hadn't been in the office very much. Why? But I think it's that time away where you kind of have an opportunity to look and say, wait, something's not right here. And so I would end up taking what I thought would be a few days away, and it ended up being 3 months. And during that time, I just realized it's as the system was set up, I was not going to be my best self in that system. And so I needed to find another way to support medicine. So I'll stop there, because we'll probably talk a little bit more about what I'm doing now and what I love, and, how that's still connected to medicine. So.
Yeah. What was it that you were struggling with? What was the system not helping you achieve?
Yeah. So I, if you have ADHD, anyone who has ADHD who's listening, executive functions are really a challenge. And you don't have to have ADHD, of course, to have that, but mine were really with organization of time. Time blindness is a huge one, and that affects all areas of my life. And so I remember distinctly at one place I worked, I had 167 charts open. That's the most I'd ever had open. And for me, it just took one day. If I had one day of clinic that I got behind, I knew that it was downhill from there, because that cognitive load of recognizing you've got 17 something odd charts that you haven't closed. The next day you have, however many patients, even if it were 12 patients, like where's the time you're going to find to close those charts from the day before? And the further away you get from closing them, you can't remember. So chart closure, running behind in clinic. And some of that was related to my ADHD. Some of it was just related to the relationship I had with patients and people seeing, a connection. I was for a while the only Black physician in the community where I served, in one clinic in particular, not always, but for quite a bit of time, especially during the time I was struggling. And so patients see you and they are really comfortable to share some things that maybe they hadn't shared before, or share it in a way that, it may not have landed that, wait, this is something we should talk more about. And so I would do that. And admittedly, this is not all the system. I struggled a little bit with how to cut people off when they were, kind of in their deep, place of difficulty. And so it was a combination of that. So really that, and with timeliness, I would get to work late and not excessively late, like at most 15 minutes. And in general, it didn't affect patients because I can literally count the times on one hand, maybe 7 times in the years where I got there and there was a patient in the room waiting. However, again, like that background noise in your head of like, I'm late again. And I know it matters because, my team now will tell you that unless there's a stressor going on, I am rarely late for anything that we do. And so, the work I do now, which, again, we'll talk more about, we know that when you create the environment for people to thrive, some of these natural things that we're punitive about actually become less of a challenge because people are not, especially as doctors, we want to do our best. We want to be our best. I didn't ask for help for so many years because I'm like, no, I have to do this like the rest of my colleagues. I cannot look like I can't do this like them, because if I can't, then they're going to think I'm not a good doctor. No thought about how my clinical, work was going. It was about the optics, and so I know, like, with the work that we do, with my own anecdotal experience, when you create the environment for people to thrive, they actually do.
So this felt like the environment was not set up in a way that you could succeed. So the interaction with the patients, the medicine you thought was going well, getting there on time, the patient actually in the room on time, the remaining aware of time in the room, plus those added cultural pieces where you were connecting on a level that the patients may not have had previously, and they're not getting charts completed, and just one day of not getting charts done, and it felt like it's all downhill.
Yeah.
This sounds like a repeating cycle. How would you get yourself out of that cycle? Like, as you saw it come up.
Honestly, what it looked like initially was, I cannot remember a single vacation I had in almost 10 years where I did not chart. And I'm not a workaholic. I'm not one of those people who like to take work on vacation. I'm very much like, I want to check out. I'm a Gen Xer, and I think I function. I'm a Zennial, they call it, like a millennial. And I love the way that Gen Z and millennials show up and protecting their time away. And I just never could if I really wanted to catch up. I spent a lot of weekends charting. Holidays, I remember, my family would be celebrating and I'd be in, a room with the door closed, hearing them, the revelry of Thanksgiving or, Christmas, because that's, those are the holidays I celebrate. And I should say National Day of Mourning, because not Thanksgiving. And I'm like, holidays are big for my family. Every Sunday we get together. And many days I wouldn't go because I need to be home charting. or come and I'd have to leave early, So the catch up was really taking away that restorative time, or just using a vacation to not go anywhere and just catch up on charting. I distinctly remember one of the times when I had the 167 charts. I had a week of vacation time away, and I used that entire week to cut that in half. I didn't go anywhere. I just made a plan with my coach at the time to catch up on charting. So I do that. As it got later, in the process when I ended up leaving, I'm not good. I sort of checked out. I couldn't, I was like, something's got to give. And one of the things we talk about in the work we do is resilience, but not the weaponized resilience many of us hear about. It's the sustainable resilience of really recognizing we are a bit of I don't want to say a closed system, but what goes in terms of what's restorative and what goes out, there has to be some recognition of that, because my grandmother would always say, you can't squeeze blood from a turnip, right? There's no blood there. And what weaponized resilience looks like is help me figure out how to make the turnip feel better so I can squeeze blood from it. And sustainable resilience looks like there is no blood in the turnip. There's only what you put in the turnip, so that if you want to get something out that's, useful and positive and healthy, what you put in has to be, positive and healthy. And it was so eye-opening for me to look at those things of well, what's coming in for you to be able to sustain this level? And I realized you don't have time for anything to come in. So this is why you're grumpy. My sustaining part was, I told myself, well, what will happen if I leave? Who's going to take care of my patients? I went into medicine to take care of my community. And so I took a lot of responsibility for that, but never thinking about, well, who's going to take care of you?
So it sounds like pretty much all your resting and outside of work time was just catching up on the day's work and the backlog of the previous day's work that wasn't completed. So there wasn't a lot of resting going on at all.
No, my sleep, I've always been a bit of a night owl. And I would look back over Facebook posts where I could see that time of my shock of how late I was going to bed was getting later and later. I'd post something like, I can't believe I went to bed at midnight last night, which is now my goal. If I can get to bed at midnight every night, 7.5 hours of sleep, I'm doing pretty well. And then over time, it was wow, I got to bed at 1. Oh my goodness, y'all, I was up till 4 a.m. That increased and increased. And so I'd be going to the office on 4, 5 hours of sleep. And I confuse people because I look younger than I am. I will be 47 in March. There's no way. At 20, I could function on 6 hours of sleep. At 47, no way. And so literally for a good, I would say at least 5, 6 years, I had a headache almost every day. I have migraines. I have migraines almost every day. I had them. And that has become almost, when I have one now, I'm like, wait, what caused my migraine? And usually I can figure out what it is. And so, yeah, every waking moment almost was spent catching up on work. And that's not even to mention calling back people in their labs, answering questions and things like that. I was in the office every day, 2 or 3 hours after I finished clinic, which I usually finish late. I knew the cleaning crew. We chat. I knew one of them that their son was in dental school,
Yeah. Yeah. So your experience and your description of life in those 10 years, it doesn't sound fun or sustainable. So you're getting to work having had bare minimum sleep. You're rolling in the door late. What were you feeling as work, the day started and you had to go to work? What was that feeling for you, do you think?
Again, initially it was excitement because
Mhm.
I was like, I get to do my childhood dream. I get to see patients. And I think like, many of the people I talk to internalize, like, this is a me problem. And every problem that's come before that, I figured it out. I'll figure this one out too.
Mhm.
And as I started to really like focus on that idea of like, wait a second, your patients who have ADHD, you don't think it's a them problem. You give them accommodations, which is not my favorite word because I really prefer, a colleague of mine, Dr. Sunny Nakai, we're doing a presentation and she talks about universal accommodations instead of, I forget the other word, but it's kind of like this, like, you know, I would say begrudging accommodations. And I think we do begrudging accommodations by and large. And universal accommodations for me is thinking about orchestrating your organization in a way that says, I know we're going to have people here who are neurodivergent,
Mhm.
I identify as having a disability. I know not everyone who's neurodivergent does. And so I want to put that out there. But people who have cognitive disabilities. And so, what are the most universal things we can put into place, so that they come into the organization knowing that there are some things that will support them. And so I think as I started to question, the shame I was having, I started to dread going into work.
Mm.
Some of the, cultural things that I think our parents' generation learned was, my mom's work ethic was impeccable and it was harmful. My mom, again, I mentioned she's a severe asthmatic, and I remember times she doesn't drive. She never learned. And so she'd take public transportation. And where we lived before we moved to the house where we would grow up in and, where she still owns the property, we lived right off a bus line. And I remember times where she would be so short of breath. It was not even a half block to the bus, you know, station to pick up bus stop. She would have to stop
Mm.
and pause to catch her breath, use her inhaler, and go, pause.
Mm.
And so we saw that kind of work ethic growing up. And so for me, it was like, you don't call in. And doctors in general, we don't until COVID, like a sniffle, a cough. No, you better be close to death if you're going to call in. And so there came a point around that same time where I started to toy with the idea of like, should I take a mental health day? And I would feel so horrible about that. So I wouldn't.
Mhm.
Um, and so, to your question, I think I started to dread going into work. I
Mhm.
would hope that patients would cancel, which was initially not a sign to me that, you know, this is something, I think of it like a relationship. One of the things I remember, I was in a relationship and a guy offered me his number and I hesitated. I was going to take it. And like for me, that was like a sign that something was wrong. I
Mm.
didn't take the number. And I was like, okay, the fact that I hesitated and was going to take someone's number is a sign. We need to talk,
Mhm.
right? It's the same like in medicine. Like for me, wishing that patients not show up. And I don't think that's a bad thing. So the fact is, like, most doctors are overworked and
Mhm.
have way too many patients to handle. And in the past, there was this like, oh, I'm excited. It just never occurred to me. People canceled all the time. And
Mhm.
so it was fine. Um, and I started hoping,
Mm.
like, I, what if there was an accident on the way to work? This is when it was really, I mean, I've only shared this with a couple of people. And again, I don't share anything that haven't worked through, but I remember thinking about the leave of absence for a double mastectomy
Mhm.
and thinking about, oh my gosh, that will be such a break from this.
Mm.
That recovery was really painful.
Yeah.
And I was thinking about it as a reprieve from all of it.
Yeah.
So it started out as like, I'm excited. I get to do this every day.
Mhm.
Um, At one group, I was working in a clinic right in my community. And the first day in that clinic, I cried because I remember being a kid and my grandmother passed away before I became a doctor. And I was so excited to be, realizing the dream my whole family had. I was the first doctor in my family.
Mm.
And then by the time I left, I was just like, I, I don't want to see a white coat. And I still get a little bit of activation, which some people know that word is triggering when I am in a healthcare setting. Yesterday for my appointment, I was like, everyone was lovely. And then I had a moment of like, my goodness, if I were back in this setting. I, so I gauge about my readiness to return to patient care on that.
Right. Okay. So that's interesting that it's something that you had worked your whole life towards. You were so excited about it, so proud of yourself for it. You get in there, you're having this experience of a constant battle between the work of the day and getting the work of the day done, and this extending into hours and hours. Had you asked anyone how they were doing it, how they managed other coping strategies for this day? What did you come up with when you asked questions?
So I think that's also when I finally started to advocate for myself. I still remember the day was because I had been doing all of the things. I had met with like our EHR staff to optimize my EHR.
Mm-hmm.
I had 2 or 3 meetings with them. I talked with my medical directors about things that they were doing
Mm-hmm.
to, teenagers were probably the biggest challenge. They take a lot longer.
Mm-hmm.
And there were some changes made to adjust for that as well. We increased the length of the visits for teenagers, which was really helpful. And we limited the number of teenagers you could have each block. So it was like no more than 3 teenagers a session. So in the morning session, the afternoon session. Um, I talked to other colleagues, when things would come up, I'm like, how do you handle this? And it was, I was becoming aware that I was trying all of the things and there were still some challenges. I identified one major thing that made all the difference. In a particular health setting that I was in, we had like medical assistants that were in, some people have nurses, we have medical assistants, and we would switch them every day, sometimes a different one from morning to night.
Mm-hmm.
And there was one medical assistant that I worked with, and I noticed that when I worked with her, I didn't run behind as much,
Mm-hmm.
and I could finish some of my charting in real time. That made all the difference because if I could even finish half of my charts in real time, it made it so much easier for me to stay and just finish, even a few of them at the end of the day or even at home over dinner.
Mm-hmm.
It's much less, laborious to think about finishing, even if, again, you just had a half day of clinic and saw 12 to
Mm-hmm.
finish all 12, than to finish 6, right? So I identified that. And very early on, I identified that and asked, and I didn't identify her. I just identified having a dedicated medical assistant was really key for me. And the response was like, well, we've never done that.
Mm-hmm.
And then the response was, well, we don't have enough medical assistants to do that. And I went to a math and science academy for gifted kids. Math isn't, I don't math anymore, but I math really well in the
Mm-hmm.
past. And this is pretty basic math. I'm like, well, every day we're paired 1-to-1.
Yeah.
Occasionally we would have like group, where like there was a group of MAs covering a group of doctors. But that was rare. And so I'm like, we're paired 1-to-1 with the medical assistant. I think we have enough
Mm-hmm.
because then you just pair me with the one. And unless they're not there, unless they're working a half day, there's really no reason. And so the people pleasing part of me was really still prominent
Mm-hmm.
till I finally, like, again, contended with the shame. And I was working with my coach. And I remember the day I finally said, there was always a conversation about, I think we should meet and see how things are going.
Mm-hmm.
There's a lack of transparency. And before I even knew what it meant to be trauma informed, I knew that there were things that gave me a lot of anxiety. And so I say, it really is helpful for me to know what we're meeting about. Is this about my charts? Like,
Yeah.
let's not be coy, right?
Yeah.
I'm sure this isn't a conversation about how's your dating life going. No, you want to know about my chart. So let's just call it what it is.
Mm.
And then I just said, if this is going to be, and this is an email, so it's
Mm-hmm.
documented. So if this is going to be another meeting where I'm told how I can do better, I'm not interested in that.
Mm-hmm.
I've done all of the things. I've met with you. I've met with the other medical director. I've talked to colleagues. I've met with EHR. I've asked everything I can ask to try to optimize my side of this. And I've asked in a lot of ways for support, and I've been told no. So we should anticipate this will continue to be a struggle of mine until I get the support I need. I'm not broken. I don't need fixing. I need support. And if that's still something we cannot give me, this will continue to be a problem. We don't need to meet to talk about that. And I remember when that was, exactly when it happened. And there was a discussion after that. And I finally got the one thing I've been asking for, a dedicated medical assistant, and the one who wanted to work with me, who I wanted to work with. And for 8 months, I didn't get behind in charting. And I know this because our bonuses were tied to charting. If
Mm-hmm.
you didn't close your charts, and most people would say this was a lot of time, but for those of us who struggle with charting, there's really no amount of time that's enough, if we don't have the support, scaffolding that we need. If you didn't close them in 2 weeks, you lost your bonus. So I got a bonus one time, and it was because of this implementation, and it was going to be taken. And I said, hey, I really want us to go back and look at the numbers, because since we've implemented this change, which was shortly after this quarter started, have not been behind in my charting, except one time, and that I had COVID.
Mm-hmm.
And if we find that to be true, I really don't think that, I should lose my bonus, because I had been asking for this for a while. And we
Mm-hmm.
looked, and it was correct. It was just that one thing. Didn't require hiring anyone. It didn't require more money to be paid. It just required making this decision that we're going to do something different than what we've done. I was told, well, it's not fair. And I didn't have the language then. It's not equal. I didn't have the language then to talk about equality versus equity.
Mm-hmm.
Equity, you give people what they need.
Mm-hmm.
But we even talk about a step further, liberation. You just remove the barrier. So if everybody is like, I really need a dedicated medical assistant, you don't need a disability or be neurodivergent, to say, okay, let's just remove the barrier, because it makes it better for everybody, right? But if we really wanted to be specific, we give equitably. You give people what they need. And I didn't have that language. So finally they did. And for 8 months, until it was decided for really arbitrary reasons that we can't do this anymore. And there was some, intermittent times of trying to do it. We did get short staffed and things like that, but I would get behind and would never catch up after that. And
Got
that
it.
would be for the better part of a year and a half.
What do you think it was about this team member and yourself working together that helped you stay closer to time and get your charting done?
A couple things. They had impeccable executive function.
Mm-hmm.
Like, they were just really organized. They were really comfortable. We had created a real rapport with, you know, coming in to interrupt. I would ask, and I asked them to, I would ask them to knock midway.
Mm-hmm.
The visit, that let me know you got 10 more minutes, or whatever you haven't done, you got to focus and get it done. When I prepare to examine my patients, I'd order everything. Like, I like to work at the computer because my short-term memory had been challenged after my ADHD,
Mm-hmm.
was really bad. And so I would order my vaccines at the end of that and everything I needed, and then go into to examine the patient. In addition, like some of the smaller things, like we had an after visit summary and different papers, anticipatory guidance we would give the patients, and even a book. And she didn't see it as excessive to grab those things for me because she really understood that it wasn't me. Like, I just want people to do everything for me. She really understood that, like, excuse me, when Dr. Lockhart has to shift her attention to do this, it's another 2 minutes to refocus. And so she was helpful. She's like, I will do whatever I can to help keep you on time. Like, she was focused on the patient and
Mm-hmm.
not focused on like, oh, Dr. Lockhart, like there were some medical assistants, they were all lovely. And I think they were just overwhelmed too, but they didn't want to work with me because they felt like it was a heavy lift. And it can be when you have someone who is neurodivergent. And I think we all have needs that we need met. And when you're not getting yours met, it can be challenging to be the person having to meet needs of, say, a neurodivergent doctor when you're feeling like, geez, I'm just trying to keep it together. She really, I mean, we still keep in touch.
Mm-hmm.
I had left clinical medicine, a few years ago and worked with her several years ago, and we
Mm-hmm.
still keep in touch. So she just really focused on the patients, like patients loved her,
Mm-hmm.
and she knew that supporting me would support the patients. Well,
Mm-hmm.
she also had a lot of care for me, because I had a lot of care for her. She had I took care of her children in clinic. And this was probably after we developed a relationship. And so she knew I cared about patients. And so I had an opportunity to explain to her my challenges, which I was very open about
Mm-hmm.
for anyone who wanted to, understand that. And so she understood that this was really like an organic thing. It was not Dr. Lockhart being particular. And
Mm-hmm.
so she would allow me to focus on the patient care. And if I were running behind, and she'd done the knock and I hadn't ordered the vaccine, she knew how to come in and help me kind of disrupt that, in a way that was not disruptive to the visit, but she had been there quite a bit. She was an amazing medical assistant.
Mm.
She
Yeah.
left the group before I did and ended up like lead medical assistant and then like office manager at her new place. So she was just a good leader.
Yeah. Sounds like you had that team together, the same target as you both wanted your patients well looked after. You were both on the same page that you wanted patients through in a timely manner and with all the work done. So it wasn't even that she had identified what you needed and was working for you. As you said, she was working for the patient, and so were you. And that combined her understanding of what you needed and her yin and yang of you
Yeah.
really made for a great team there where you could concentrate on the pieces, your expertise, and she could help you with the things that you were finding as limitations in your clinical space. So fascinating. So tell us then, what did you move into? What
Yeah.
then started sparking your interest?
Yeah. So probably about 3 years before I would end up leaving, I started to think of like what it was I wanted to do. And I realized that I had a leadership role at the time, and this was my third third clinical position when I started at the last place, third clinical position in 4 years. But I would end up staying at the last place quite a while, um, longer than I'd stayed at the other two. And there was a recognition that I'd gone into medicine thinking I would have some impact on my community. And I just didn't, I realized that the impact I wanted to have, I would not be able to have at the bedside and even in the leadership position I had. I think it's just the structure of healthcare right now.
Mm-hmm.
Um, One of the things I've read about people with ADHD is that we have this deep sense of justice. And so I think that can get us kind of wrapped up in something sometimes that as physicians that it can be challenging to kind of create the guardrail of like, okay, this is not the thing I should be focusing on with the patient. And so I started to, I was a justice, equity, diversity, and inclusion leader. And there were limitations just being in a health system. And that's all health systems, I think, not everyone, but almost all of them. in the US for sure. And I was thinking about what would it look like to do this work outside of the, kind of the restrictions of a health institution and do it on my own.
Mhm.
And that was happening. My coach had said to me, have you thought about coaching? And I had not mentioned it because I didn't want to give the impression of like, oh, I can do this. And she knew me long enough. We've been coaching for 10 years that she was like, Kerri, of course not. I think, there are things that you want to do that really match well with that. And, that's a small piece of, what I think, you're saying you want to do. So we kind of teased out this idea and I wrote down some key things that I wanted to be asked to come in to organizations. I
Mhm.
wanted to work with leaders in organizations because that's where the decisions are made to really create culture change. I had no idea what that would look like.
Mhm.
And I'm math and science, so I'm like, okay, what are the steps to that? And I think there is something that be said about writing down your vision and then staying open to look for opportunities that can move you closer to it. Because I didn't really have a path. I grew up with working class parents who are like, get a job and you have a retirement plan. And, so my mom was really supportive when I wanted to leave. And there was some fear of like,
Mhm.
what are you going to do? Like, I'm not wealthy. I didn't have tons of money saved in my, in the bank. I, definitely had retirement started. And so she's like, oh, we'll figure it out. And I had connected with my CEO and
Mhm.
friend, Dr. Kimia Saraf,
Mhm.
along the way, but hadn't like really recognized what the work she was doing. And then I did a fellowship with ACGME, which is, the accrediting body for residencies, accreditation council for graduate medical education. Um, and that started from a very small, you know, post on social media in a group that I'm a part of, Dr. Bonnie Simpson Mason, who was brilliant. And it was around, it was probably, I think it was before George Floyd, but it didn't start to happen until right after she had posted that she wanted to connect DEI, so diversity, equity, and inclusion leaders around the country to talk about how do we do DEI work well. And
Mhm.
so I remember the first meeting I couldn't make. It was on a Friday. I was in clinic until some awful hour, maybe like 9 o'clock. And I was like, is this going to be recorded? Anyway, I started going to those, they were called DEI forums. And it was really an opportunity to have people from around the country who were doing DEI in a really meaningful way do didactics. We asked them questions. And that started as this, I think it was 20 people who came to the first meeting. And Bonnie, again, she's just simply amazing, developed a program that would be implemented in hospitals and healthcare organizations called Equity Matters. And ACGME developed a fellowship with her out of that program because she, for a time, was the vice president of diversity, equity, and inclusion. I joined that fellowship, and Lodestar were part of some of the facilitators for that program. It was then that I really, even before then, as George, we were doing it before, I think, the small DEI forum that
Mhm.
developed into the Equity Matters program. Kimia had come to one of the DEI forums to do what's called a safe space
Mhm.
because people were really struggling, especially after George Floyd, with doing
Mhm.
this work in spaces that were just challenging. And when I saw her, I was like, wait, I know her. We had been friends on Facebook since like mid 2000s, like 2017, 16. And that's where she really got to know me. I really used to write a lot more about like just social issues and personal things and
Mhm.
writing from this like somewhat of a trauma informed lens, but didn't really know the full gamut. And so we connected there and I started truly with a small group coaching that she provided an invitation. And this group that Bonnie had started was predominantly Black doctors, but it was other it was diverse, but it was mostly Black women doctors. And so it was a small group coaching, group of women, Black women coaching. And it was the first time that I was like, oh my gosh, this is not just me.
Mm.
Some of them, I mean, these are like amazing, brilliant women doing all of these things. And here I am thinking like, of course I'm struggling because I'm not doing anything amazing. You know, the stories we tell ourselves. And so from there, I connected with Kimia and did some individual coaching.
Mm-hmm.
Um, and it was through like kind of that relationship of her seeing, you know, my thoughts that I didn't know were trauma informed, this ACTME fellowship that she would ultimately lead. And by the end, I became a facilitator for that. I learned about TMMC, and I had been thinking of coaching. So I had already joined my coach training program, an accredited coach training program.
Mm-hmm.
And then did TMMC. And so it was just like the stars aligned. Just as that all happened, I left clinical medicine. And admittedly, I'd applied for fellowship at Harvard. That was really like seemed ideal for what
Mm-hmm.
I wanted to do in terms of like DEI with leaders. And I got waitlisted, and I was devastated and thought that was the end of my work. And I did TMMC. And as I left clinical medicine, Kimia and I talked about what it would look like if I did some work with Lodestar. And then soon after that, we got a contract that would kind of explode. And so we've been working with a large public health department that is exactly that. We started with the top
Mm-hmm.
executive leaders of the organization, and we go in and do trauma-informed, trauma-responsive leadership. And that may seem different from justice, equity, diversity, and inclusion work. It was doing TMMC that I became very aware that you cannot do justice, equity. I mean, it's challenging, I should say, to do justice, equity, diversity, and inclusion work without doing it in a trauma-informed container. And I was like, this is what was missing.
Yeah.
And so I shifted to work with Lodestar, and that's what I do exclusively, facilitating trainings for organizations. Um, we do public health, and I mean, we do all industries. There are some of our
Mm-hmm.
team who are lawyers, and they do this in the law industry. We are potentially doing some with schools. Just depends on, you know, the logistics of working that out, but primarily healthcare. And so it is my endeavor that we change the culture from
Yeah.
the top so that people recognize that they're potentially losing great doctors because of this rigid box that we
Mm. Yeah.
believe doctors have to be in.
So if you were now in the position you're in now, looking at Dr. Lockhart 10 years ago, as she comes into this place that she has longed to be in and is super excited to be there, but she's starting to have these noticings about her day that aren't going so well. What do you think would have helped you, or where would you start for her now, where from the lens you're in now?
Yeah, yeah. So it's interesting because I think of like, I say if, but it's a when I go back into clinical medicine, like there's certain things that I won't budge on. And so that's knowing now, right? And so if I didn't know, I definitely would have addressed earlier. And really, it's so tough. And so I say this knowing that like I'm speaking from a bit of a privileged perspective and not being
Mhm.
in medicine, not being in the situation. And I offer this from the standpoint of like, I felt like I was dying when I was in medicine. And when I got to that point of falling off the cliff, it was killing me
Mm-hmm.
slowly. And I think if we think of it in terms of that, it becomes easy to hear what I'm about to say. I think I would know if I knew what I knew now, I would be unwavering, and inflexible in ways about the support I need.
Mm-hmm.
Um, because it's not a question, you know. it was a DEI person in that small coaching group actually who shifted my perspective. Um, she said to me, if you were hearing impaired and you said that it's challenging me for me to hear blah, no one would get away, at least, and likely they wouldn't say, well, your other colleagues hear okay, why can't you?
Mm-hmm.
And so she offered, don't allow people to make you think that your cognitive disability is any less of a disability or your neurodivergency is any less worthy of support than someone who has hearing impairment. And that's not to say that people with physical disabilities aren't shortchanged all the time in medicine.
Mm-hmm.
And I think I would be inflexible
Mm-hmm.
because it's not a request, it's a need. And
Mm-hmm.
so that would have looked like going into medicine now, like I absolutely refuse to work without a good scribe. And so there are different scribes that are electronic. It doesn't have to be a person there in the room. Personally, when I think of like equality, equity, liberation says we offer a scribe to everyone. We just remove the barrier. Because
Mm-hmm.
what I learned was most of my colleagues would have benefited from a scribe, not just me with ADHD. And until we get there, this is what I need. As much as I need a computer to document, as much as I need access to EHR, I need a scribe. Like the idea of getting behind and charting again and being overwhelmed like that is simply just enough to make me say I would never go back into medicine.
Mm-hmm.
Um, I would be unequivocal about what it looks like to address things as they come along, like recognizing, I think as we plan things, there was this thought that once we put these in place, this is it. And
Mm-hmm.
this is a, moving target.
Yeah.
There are some things we try and they work and then they stop working, or some things we try and they don't work. And so being really clear about, I want us to have some dedicated times that we meet, but also understanding that if I find prematurely that something's not working, there's space for us to come back together and co-create a new, um, process that works. Um, that the process is clear and efficient. At one of the places I asked for accommodations, when I finally, got the courage, it was a year almost before some very, very simple accommodations that probably could have been implemented within 2 to 4 weeks. And it took a year.
Mm-hmm.
So, really discussing like that process, and looking for places that make the process very clear. Um, this is what it looks like. This is, what the steps are. This is when you can anticipate
Mm-hmm.
responses along the way. And if they don't make it clear, being really comfortable to ask, what's the process? What can I anticipate? How long should I anticipate this taking?
Mm-hmm.
And, what are the, you know, specific, stipulations for denying a certain ask? But just really being more centering my needs for the sake of being able to be the best I can for patients, not centering in like nobody else matters. But I think oftentimes we feel like we're being selfish. And when it comes to neurodivergency or disability, and again, even if you don't have these, if
Mm-hmm.
charts are a struggle, we are worthy of getting the support we need to
Mm-hmm.
practice medicine well. And so just really centering that of like, I want to be the best provider. If you are an APN or, I
Mm-hmm.
want to be the best doctor. And
Mm-hmm.
this helps me do that, and being really inflexible about that, flexible about everything else. But if I were using mobility of a having mobility with a wheelchair, one would ever say, well, we don't have a ramp. So for a part of it, we're going to need you to walk.
Mm-hmm.
And I
So
want us to think about
interesting.
those things the same way, our needs,
Yeah. Yeah. So interesting. And I'm glad that you were able to identify what it was that was helping you. Because I think sometimes we're even in that struggle, not even sure what it is that we
Yeah.
need.
Yeah.
And so you had tried a whole lot of options and you'd found one that was really working well for you. But the ability to even
Yeah.
say, I need help. I'm not sure where that help's going to come from or what change is going to look like. But this working every night, all night, and every holiday and every weekend, this bit's not
Yes.
working for me.
Yes. This
And
is something, I'm sorry, go ahead.
yes, no, that's okay. Yeah.
Yeah. This is something that the presentation that Dr. Sunny Nakai and I will be presenting, but she's put a lot of it together. And it's one of the things that she said, she gave the example of like for holidays, right? A lot of times here in the States, the time off for holidays or how we might change the schedule is focused on like Christian holidays. And, instead of just asking, oh, I know that there are, for example, Jewish holidays, you ask Jewish people, you know, maybe, oh, I forgot that they're Christian, we only focus on Christian. Let me just make sure I ask Jewish residents or attendings what days they have off. Put it to everyone because sometimes, what you'll find is there's Seventh Day Adventists and Jewish people who observe Sabbath on
Mhm.
Saturday. And they may say, well, I'm open to working every Sunday. And when you just limit it to this, group because you think they're the only ones who need
Mhm.
to be accommodated, you you're being equitable in a way. But again, if we take that extra step of like, how do we just remove the barrier?
Mhm.
That's the liberation. It makes the view better for everyone. And you just offer, okay, let's hear from, a survey or whatever. What days do people find a struggle? Like there may be one person who's like working more than 3 nights in a row is a challenge. I distinctly remember that being me for ER nights and residency. And so we broke them up.
Mhm.
And what would it look like if we asked everyone that?
Mhm.
Maybe I was the one who spoke up. And so if you find that there are lots of people that way, yeah, it requires more work.
Mhm.
And we're not shortcutting, supporting residents and physicians to be their best
Yeah.
selves. And
Yeah.
so, absolutely, asking everyone, what is it that you need? This is a place where we want to support everyone. You don't need a disability. You don't
Mhm.
need, and sometimes, like you said, if you don't know what you need, we can talk about some of the things that other people have tried.
Mm.
Um, at a presentation, I asked, it was a group of probably maybe like 7,500 doctors. How many of you have ever said to a direct, your leader, not because like your computer isn't working or something, but something inherent to you, I can't do that thing the way that everyone else does. I can do it with some
Mhm.
scaffolding or support, but I can't do it. And I think like 3 people raised their hand. I was one of the people.
Yeah.
I remember that day. It was really, outside I probably looked like really calm. Inside, I was like, wanting to puke because I was saying, I can't do this like everyone else. I can
Yeah.
do it. I just need a little extra support. And sometimes you don't know what it looks like, or the container's not created to feel safe enough to say what it
Mhm.
looks like. And as a leader, you can offer that.
Yeah. How do people find you, Kerri, if they're interested in working with you or learning more?
Yeah. So, Lodestar, our website, I'm like now having like total brain freeze. I literally post this website and share it all the time. So it's www.lodestar. So people often want to put Lone Star, like the
Yeah.
steakhouse, but it's L as in Leo, O, D as in dog, E, P, C. So P as in Paul Cat, lodestarpc.com.
Okay.
And on that website, you can connect there. I'm also on formerly known as Twitter.
Yes.
It seems so, I don't know, weird to me that we're calling it formerly known as Twitter. twin_doc, DOCK is my, but if you search Kerri Lockhart, I think I come up as well. And LinkedIn, of course, I'm on LinkedIn.
Is there anything we didn't talk about that you wanted to share before we finish up today?
I don't think so. I just encourage everyone to know that you're a great doctor. And, I am very comfortable letting people know I was a great doctor. I was not good at organizing like the clerical stuff. And at times I didn't feel like my patient care was valued. It was valued, what I could produce. And I understand money is needed to make medicine work. And so I'm like, well, we can make the revenue if you give me the support to, do the things that are absolutely important. Closing charts is important. And I think if we remember that we are worthy of environments that support the parts of us that are, we're not a monolith as doctors. This box that has been created, I'm here to try to break open the box so that we can, exist in organizations in ways that are healthy and do the work that needs to be done.
I love that. I love that there's people out there helping you fix your systems, which is wonderful. So thank you for this conversation. I think it's going to be very helpful for those who are currently struggling and not knowing what they need, but know that they need something to help them create more sustainable. So really appreciate your time today, Kerri.
Thank you so much for having me. It's been such a pleasure.
Yeah. Have a great day, everybody. Thank you for being part of the Sustainable Clinical Medicine podcast. If you'd like to learn more or join us to help you get home with today's work done, go to chartingcoach.ca. There you'll find all the information on the Premier Lifetime Access Charting Champions program that is helping physicians get home with today's work done, with all the proven tools, support, and community you need to create time for your life outside of medicine. We would love to see you there. Until next time, thanks for listening.